important building block at the very bottom of all of this is the importance of diet and lifestyle and people's general health and well-being. If we are not in control of sugar consumption, if we have poor diet and lifestyle in place, then we certainly increase the risk of dental decay. But it is a well-known and well-researched fact that fluorides, in whatever format the decision is to decide to deliver them, at a population level will offer a level of population protection to dental decay. And in New Zealand, the two methods which are used across our communities are fluoridated toothpaste and water fluoridation. Around 56%, 55, 56% of the population have access to community water fluoridation. For the rest of the communities, we're relying on fluoridated toothpaste and the issues of diet and lifestyle and general health. Once we move beyond the population picture and move to individuals, well, then there are other methods that can be put in place. Extra home products, professional prevention programs, and we have those in place for our populations, both through our publicly funded programs for children and adolescents, and through our private dental providers for adults. And there is evidence to show that community water fluoridation offers an ongoing benefit for the New Zealand population where it's in place. The graphs in this slide are from a study that was undertaken between Canterbury and Wellington in the late 1990s and reported in 2004, looking at the school children who, 5-year-old and 12-year-old children who were in the school dental service in Wellington and the school dental service in Canterbury. Canterbury at that time having fluoridation only in Ashburton and Methven, Wellington having fluoridation pretty much everywhere except for Tony and Paikapariki. And what Peter Dennison and Martin Lee found in their study was that the 5-year-old children had a 30% lower level of dental decay in Wellington, and the Year 8 children, or the 12-year-old children in fact it was, had a 40% lower level of dental decay in Wellington, after controlling for factors like socioeconomics and ethnicity. And that those differences applied across the socioeconomic groups, which are measured there as, marked there as New Zealand Deprivation Index, and across ethnicity groups. And that was similar direction of finding to what was found in the York Review, which was alluded to earlier, which did come out looking at a range of studies. What they did was what's called a systematic review of the literature available and looked at the consensus of that evidence. And what the York Review reported was that there was a 15% increase in the number of children with no dental decay across the consensus of those studies that was undertaken and reviewed in the York Review. There were a range of findings, but the median outcome was 15%. And here in Hawke's Bay, we see an evidence that's looking in the same direction. These numbers are from our routinely collected data between 2007 and 2011, comparing our fluoridated and non-fluoridated 5-year-old children. And if we look at those two groups, overall we have 7% lower level of decay in terms of the number of children with any decay at all in the fluoridated part of our district, and that is basically Hastings, Havelock North, a little part of Flaxmere until through that period, and at this stage Waipukurau as well. When we then move to our Year 8 children, that 7% number persists. We have a continuing 7% difference, regardless of the fact that we throughout that period now have been seeing those children on a yearly basis, providing them with prevention services, providing them with treatment services, providing their families with oral hygiene advice and dietary advice. There is still a 7% difference between the fluoridated and the non-fluoridated group. And we have heard the figure 28% mentioned. What we are measuring there is the number of decayed, missing and filled teeth. Previously we were simply looking at how many children have got any decay at all. Once we start to look in the 12-year-old children, or the Year 8 children, 12 and 13-year-olds, at how severe is that disease, our difference is a 28% difference between those two groups across the period 2007 to 2011. And it's not just about the children. This research from Australia looked at adults who were born pre-1960 and between 1960 and 1990, so two different groups. And the reason for the break was that community water fluoridation essentially started and is now very widespread in Australia in the 1960s, the early 1960s. So what the researchers did was then asked people how long they had lived in various places and then worked out whether or not those areas were optimal community water fluoridation levels or not, and then divided the groups into 25% of your time in an optimal area or less, 25 to 50, 50 to 75, or 75% or more. And what they were particularly interested in was this an effect that happened because you were born in a fluoridated area, or was this an effect that carried on because you continued to live in the area? And the only difference between the groups is for the group who've lived in a fluoridated area for more than 75% of their lives. In both cohorts, the level of dental decay, the proportion of teeth affected by dental decay is 11% and 10% difference, so essentially the same. It doesn't matter whether they were born pre or post fluoridation, the important factor was living in that area for more than 75% of their lives. And so the evidence on effectiveness is there. The New Zealand national data, the Australian research data, systematic reviews around the world, and our own Hawke's Bay local data are all pointing in the same direction, which says there is an ongoing benefit from community water fluoridation over children and adults' lifetimes, provided we retain our natural teeth. And those small numbers add up. Here in Hawke's Bay, we have around 1,700 children in our community oral health program in each age cohort. Around 800 of those children are currently decay-free. In the children who do have decay, our dental therapists are managing between 2,500 and 3,000 teeth affected by dental decay in each cohort. That means they've got fillings to do, they've got extractions to undertake, they've got care to provide to maintain those teeth in a healthy state. If we had fluoridation in our non-fluoridated group, if we were able to extend to the greater proportion, or because it's 50-50, turn around the other way, we would have 50 to 60 more decay-free children in our fluoridated area, or we expect our decay levels to go up to 50 or 60 more children with decay if we lose fluoridation in this area. We expect our decayed teeth numbers to go up by 350 to 400 teeth per age cohort. And what that will mean for us as a district health board, and for our staff, and for you as the payers of our service through your taxes, is we will need to put more resources into our community program to look after that extra level of disease. And there are review reports that have been talked about already. In fact, there are 4 quite big ones that have been done in the last 10 or 11 years. So going around that slide from the top left to start with, the UK undertook their report, now known as the York Review, published in 2000. The Americans undertook their Fluoride in the Drinking Water report, which is the National Research Council report that's been talked about in 2006. The Australian National Health and Medical Research Council put their one out in 2007, and then the European Union published a report in 2011 actually. The 2010 report was a draft. All of those reports have looked at a range of health factors. Dental fluorosis I will cover in a moment, but in terms of infant intake, bone fracture, cancer, IQ and brain function, the reports all say there is information to be debated in this context, but there is not harm that should mean that we should stop community water fluoridation programs. None of those reports recommend the ceasing of community water fluoridation programs. In terms of dental fluorosis, it is an accepted consequence of having a community water fluoridation program that very mild and mild dental fluorosis will increase. When we're looking at the slides of the teeth on the picture there, the top teeth have what is called normal enamel. That is regarded as normal. And the middle and the bottom teeth have very mild or mild dental fluorosis in place, the extra whitening on those teeth. And it is correct to say that the proportion of children in New Zealand who live in a community water fluoridation area will increase from 15% in a non-fluoridated area with very mild or mild fluorosis or diffuse opacities on their teeth to around 30%. It is a cosmetic change to those teeth, an increase in the whiteness. The damage point, which is measured for, and the point has been made about whether or not we are looking for markers or endpoints, the accepted endpoint is moderate fluorosis or worse, moderate or severe fluorosis. And then you are talking about brown stain change, enamel pitting, or breaking down of the enamel surface. And all of the studies that have been undertaken in New Zealand over around 25 years, including the 2009 Oral Health Survey, and specific studies looking at fluorosis, have found no difference between our fluoridated and non-fluoridated areas in the levels of moderate or severe fluorosis. So yes, as a community water fluoridation area, we're accepting very mild and mild fluorosis if we accept the program. But as we've already made, Peter Gluckman, the Prime Minister's Chief Science Advisor, has said, the science of this is effectively settled. It is a safe measure to undertake. That doesn't mean you shouldn't continue to monitor the science. But it's much easier if you want to seek to advance a values-based discussion about whether we should fluoridate the community water supply by making the science sound scary or more uncertain than it is. As Sir Peter Gluckman says, the values debate is critical for a healthy democracy, but it can't proceed usefully if the debate is taken to be about the science. And so the elephant in the room is actually that this does work, that there's a health benefit outweighing the proposed health risk, but what's being decided here is whether it's my choice and my freedoms versus benefiting my community. And that's what needs to be decided as part of this referendum. And Paul Connett says it's not ethical to undertake this, but what Paul Connett is doing is applying a medical treatment model to what is actually a public health measure. A public health perspective needs to be taken to this. And we do this all the time. And when you're making those decisions about whether or not to undertake a public health measure, you do restrict a degree of personal freedom for the greater good of your community. And as Russell Wells, the Children's Commissioner and local paediatrician, says, that's reasonable when you're reducing the health inequality, substantially reducing ill health, improving outcomes for a vulnerable group in your society. That's when communities make those sorts of decisions. And fluoridation of the water supply is the single most cost-effective measure we have to improve oral health, particularly for children. And so we make lots of decisions about public health measures. We make decisions about compulsory bicycle helmets and compulsory seatbelts. We make decisions about alcohol and driving in curfew areas. We make decisions about iodine and folate and iodine and salt and folate in bread. And fluoridation is in that same continuum. That is the decision that the community needs to make, whether it wants to apply that set of values in the context of this referendum.
Thank you. Okay, so I want to continue talking about community-wide decision-making and values. And this referendum is your chance to have a say on the continuation of water fluoridation in Hastings. And I just want to recap what Robin has covered. Hastings water has been fluoridated for the last 59 years, so that's since 1954. And what we mean by that is the level of fluoride that's currently in the water is topped up to 0.7. Water fluoridation is part of a package of measures to improve oral health and reduce dental decay. It provides benefits over and above that of toothbrushing and use of fluoridated toothpastes. And these benefits reach everyone, regardless of income or access to dental services. And we are still seeing those benefits in Hastings. Water fluoridation is effective, it's safe, and it's affordable. It provides benefits to our whole community for $1 per person per year. The science is clear, but what the referendum is really about, and the choices that you have to make in this referendum, is about values, not about the science. For water fluoridation, you have to weigh up the benefits for the community as a whole, what we call the public good, versus your personal choice. And if your personal choice is not to have fluoride added, then you're removing the benefits for the rest of the community. And in particular, the benefits for children whose parents can't or won't brush their teeth or don't have a healthy diet. Your personal choices can lead to a loss of public good and a worsening of oral health. For us as health professionals and for the DHB, we believe that the benefits for the community outweigh the impact on personal freedoms. You're weighing up the public good versus personal choice, children's rights versus adult rights, equity of outcome versus equal opportunity. But I want to touch on cost. Cost is very important in today's world, and we do need to spend our health dollars wisely and where we can get maximum benefits. There truly is only a fixed amount of money. Water fluoridation is the most cost-effective intervention that we can put in place to protect children's teeth and children's health. I can't think of anything else at $1 per person per year that we could spend to get the benefits that we're seeing. So how do I decide? How do you decide? You have the right to be well informed and to choose, and that's what Robin and I are here tonight to talk to you about. As you make your decision, we would like you to consider who's advantaged by fluoridation and by how much, who's disadvantaged and by how much. Are your fears being played upon? And use this opportunity to ask questions so that we can make your choice easier. And I just want to leave the final word with Russell.
fluoridation